Embryo transfer, the final destination of all our efforts, because this is the point where everything starts for a pregnancy. So I will move on quickly. Through a process of training and education and research, from the first guidelines in Europe about OPU, first in the world about emphasizing the ultrasound significance, the survey that we have performed 2 years later on, the first in Europe about embryo transfer standards, and finally, after 2 years of struggle to make this paper as simple as possible, we have the first paper that will be for this presentation the basis. So I will propose to you to print it out, to read it, and to have it alongside about this presentation, recorded by the video or when you see your notes. So we move on. So, well, for this paper, actually we proposed 31 standards for embryo transfer. From these, 8 are relative to ultrasound, and if I, explain in detail, we have 30 bullet points about standards of embryo transfer about ultrasound. As I said about the OPU, is the same thing for embryo transfer. Recording and evaluating is a must. So I will move on as fast as I can, so I can show you some images, and I will talk to you about effectiveness, how we can measure our effectiveness, and what we need to do about training. So what I will do here in the paper, these are the highlighted places about the standards, what we suggested, and I will move on very quickly about some comments. So the pre-embryo transfer diagnosis for IVF or indication of any treatment has nothing to do about the ultrasound study, about how we do the embryo transfer. So this is why, and the Professor Nazar said before, and others experts here, we have to include the cervix. We need to encourage to check the cervix. And sometimes you may find things that you don't want to see for extremely rare cases like intracervical cancer, based on Doppler without any other sign and with normal cervical smear. So it's very important that we integrate. The cervix is not a point where I know that in front of me I have a uterus and then I go up. The cervix is a part of the most important part for us to pass through to have a good embryo transfer. So for those that they do high COSI or high FOSI, and you use intracervical or intrauterine catheters, you have a double benefit because you don't need to do mock-ET because the diameter of these tiny catheters are the same, so you will see if the catheterization ability of the cervix is good or not. So for those that have seen problems in the cervix, difficult to pass through catheters for IUI, the office hysteroscopy is a must. In my personal now practice, I do office hysteroscopy to everybody. And of course, what we said before is the ultrasound machine. We have to have high-end ultrasound machine in theaters, in the rooms where you do the OPU and where you do the embryo transfer. I have enough to see huge fantastic big units, I have very much money, everything there, and then they have the crappiest machine inside the room. And I know that all of you have noticed this. Very few units have good machines that they have even arranged settings about what we're doing. And we need to talk about the assistant role because you are not solo, you work with an assistant. So for example, in pre-assessment here, you can see a niche, you can see a uterus which is very strange, you have to treat, you have to consider that the women that have cesarean sections and you have IVF or embryo transfer, it seems to have a little less success. Or another case, for example, here, where you have small fibroids about 2 centimeters that can modify a little bit the trajectory of our catheter. So I move on. You will find, and you read in your time, I will go and I will say that the blood and the uterine body, the positioning is very important. I mean, you shouldn't put too much fluid in the bladder, not because you will be in pain, not because anything else, because you have the pseudoesthesis of enhancing your ultrasound image. So your setting of your machine is the one that it must be adapted to the uterus and embryo transfer. So having a huge bladder, you see perhaps the uterus better, but there's a pseudoesthesis. So you don't need that to do. You don't need to fill the bladder when it's retroverted. Just you need to use appropriate couches that they are for these reasons. Now, in these ones that I will show you, and you have in your hand note, the yellow ones, they are indirectly. Indirectly, why? Because the pre-assessment, what we do, has a bias. how many of us really we know how to see adenomyosis, focal or diffuse. So imagine how many bios we have in all our researches, in all our outcomes about uterus normal, but it's not normal. And of course, clarity of image, clarity of what we're doing allow us to have faster, in a way, timing for embryo deposit. Another thing is we need to have some standards where you can say what means a difficult embryo transfer. It was a colleague telling me, well, I cannot, I do it in 2 seconds. I didn't know what was the wrong. And it happened to me that it has all easy, and the day that I'm doing is not right. Why? It's the positioning, the preparation of the cervix, but as well the clarity. And the clarity that you want to do is in your settings that I'm going in a moment. This is a list that you can reflect your own practice. I mean, by all means, all these, you don't need necessarily to take photos. Or, these will be given to you as a PDF. And of course, I need to remind you that this is recorded presentation, so you can see us or which part you want again and again. The patient, avoid lithotomy position, avoid excessive bladder, we said, and one of the things for the trainees, but as well for even for the more seniors, to know how to use the speculum. Yes, people use the speculum in different ways because we can, with very small movements of the valves of the speculum, align better the cervix. This is a kind of gynecological couch what we need to use. Why? Because if you use the couches in theaters, these are not designed for this kind of things. So this one, for example, can make upwards a little pelvis, the gravity takes the bladder and the uterus and the bowels backwards, so it's easier. And as well, give you a lot of flexibility of your movements when you want to do the embryo transfer. Another thing is about standardization, where you put the machines. Do you feel that we have to know where the machine needs to be? Of course, because the machine, a general rule is from the side that is not dominant. I'm right-handed. Right-handed is my hand that fills and do the catheterization. Left hand is my piano, my machine. So if it's like that, the machine is to my left side. Of course, to the opposite side will be my assistant. So this must be some sort of standardization, because it happens that you do what you do, but the assistant may not be able to adapt the image as it must be, or when we have an active assistant, you need to optimize the image as good as you can. This is a list what you may need to think and to check when you do your ultrasound. Of course, the embryo thickness, the endometrial thickness, but it's not just the thickness. It seems that some people now with high sophisticated machines can differentiate this whitening, this hyperchoreogenicity within the trilaminar endometrium. So perhaps this is a new sign of maturity of endometrium. It's not just, yes, we are 9-10 millimeter. It's the portion of this whitening within this thickness. Of course, we need to exclude fluid. All this is quite easy to read. And we need to measure the length of the cervix, the length of your uterine cavity, nothing else. It's just to adapt and to know how to choose your catheter. Some wombs are very long. You know, we have long shoes, long legs. It's the same thing. So some women may have a normal uterine cavity, but excessively long cervix. So you may not be able with your catheter if you haven't calculated this. And actually, you can pre-calculate this if you do hyphosi with your measurements at this moment. Ideally, demonstrate to your friend, to your assistant, with your cursor, where you want to go, where is the point where you need to stop. Leave for a couple of 1 minute to align, to move around, so she knows to help you exactly where you want. Don't go directly, yes, I'm ready, and you have a passive assistant who just has a probe just, holding. Some paper shows that there is no difference between sonographers and midwives and nurses. Yes, of course, if I hold it, I hold it the same way with everybody. But nobody tells them that the energy of your ultrasound, of the ocular point, is in the middle. So when you pass through the catheter, when you do this final movement, she needs to follow you, not only to see where is the tip of the catheter, but as well to give you the maximum energy of all the field. So you need to train here. Optimization of the image. my colleague, Professor Andriana, already showed us a couple of tips about optimization. We need to optimize the image, not because we like it like this or not. We need to adapt the optimization to the echogenicity of the patient, and this is different after a fresh cycle or a thawed cycle for frozen FAT. So, yes, we need to have knowledge about sonographic field, an angle, the filters that we use, the dynamic range that help us to differentiate better the tip of the catheter, the depth, the zoom, to know where's the button, at least if you need it to get a photo, and to arrange cine loops. You may have 15-30 seconds. Do not use excessive power. Be able to not overexpose the area. Don't forget that the bowels that are moving around make shadowing. So you need to make slowly a generic setting about your embryo transfer with your name. Do not use the basic setting of gynecology. Yes, you can see. In all machines you can see. And slowly you can do ET for obese women, ET for thin, ET for whatever. So you have already prefixed settings that you can finalize, and you will be happier and better without, be stressed, oh my God, what is this in front of me? Now, what we know about embryo catheters? Yes, we train you, we tell you. What do we know about catheters? Which is your criteria to choose a catheter? Yes, we have categories like flexible ones or stilted or rigid ones, but what is the difference between them? So some new materials come. There are some with memory, some that you can bend, some that are rigid double lumen. They can be, this is not available yet. There are some companies that they do a future sort of research about even integrating sensors inside to know the pressure that we create in the tips or probably inside the uterine cavity. Hydrophilic coating, so there is no stuck embryos inside. But actually, this is a photo of different kind of catheters. Yes, we all agree, I hope, that flexible ones are a little better. The reason which are better is because they adapt easier in the sort of tunnel of the cervix, and most likely, if you do it very gently, with good clear image, you don't traumatize the endometrium. That's the theory. But what are your criteria? When I was in Amsterdam in the latest ESHRE meeting, I asked all the companies, I'm sure to go all the companies, and there were none who could give me one image of their product from the ultrasound point of view. So we have to ask in ourselves which kind, because the artifact that happens inside is quite different. Yes, it's something whiting, but you finalize the image so you know exactly where's your point, not just obscure image of whiting of your catheter. A reason why we have retention of embryos can be a catheter, because some catheters may create a difference of pressure inside. So it's not just I take one and then here it is. I used to have this catheter and I move on with the ability, and I pray to the God that I will do my job well. Okay, so I just move on with some examples. This is what I called a zoomed. So we have a zoom here. We have the cervix, the catheter already. Here you will see in a moment, or you have seen it, the two small embryos. The bladder is here. We can repeat it once more. So this is a little more focused area of work. So this is what I personally prefer, but never mind, we will see different kinds. These are the videos. From these videos are the photos that they exist in the article that came in September 2022. This is a deep ultrasound field. For example, here we have a depth that we have the whole bladder, the uterus. Again, here we have the artifacts, the reverberation that happens between the valves of the speculum, the catheter that comes slowly inside. You can see that there is tiny flexion of the image left-right because the assistant tries to find. And it's not just, okay, I'm going there. You need to see the whole process where you approach. Sometimes you may lose the tip because the tip is going diagonally and the field of the ultrasound is vertically, so you may be a couple of millimeters further. A retroverted uterus. This is an easy retroverted. The retroverted uterus are the hell most of the times, because some of them, they are very posterior, so you lose quite a lot the depth. For example, here you can have a bowel that obscures the image. But you can see here, again, a very, I hope, smooth embryo transfer, and the dot is the embryo. We can play this together with this one. We can measure things as well that we can evaluate. For example, from the fundal endometrium, the distance where you stop the tip of the catheter, but as well where is the bubble if you use bubbles, or at least the fluctuation of this pixelization where you're supposed to be the flow of the embryo. So here, for example, it seems to be 8 millimeter and more than 5. This is just an image which is quite rare. You can see a mirror image is an artifact. It's like two uterus, but actually it's not. It's an artifact that happens sometimes. So don't be mistaken. So the effectiveness of embryo transfer is easy. It's how many women get pregnant. So we need to stratify our results with a pregnancy test and so on. You see all this sort of information. However, we have some bias. First of all, do we have adenomyosis or not? Adenomyosis is not a good factor associated with endometriosis. We have new theories now, apparently, that is a disease coming with the aging of the uterus, and perhaps we don't really know if it is a proper normal uterus or not. The high-resolution ultrasound trilaminar or not is a matter of research. The high-resolution 3D or 4D reaching the ideal area is truly the best way to find where you are, but it's very difficult technically, and very few of us, at least our generations, allow me, well, 50s, that we are autodidact. We never had this type of training before. So the new ones, you need to demand a proper training in 3D because this will be the evolution. And of course, there can be some people do endovaginal, with transvaginal way embryo transfer. In these cases, don't think that it's some strange thing. Where you put a 1 centimeter, 1.5 centimeter catheter in the cervix, you remove the speculum, and then you move the transvaginal. It's like a semi-hycosi-hyphosi, and then people think that they feel better and see better. But if we are able to have a good image abdominally, you may not be to the hassle, but it's something that is valid. It's not a bad idea. So why we have to evaluate ourselves? It's not only to know, yes, I'm successful, I helped this lady, but we need to have a sort of systematic audit about our effectiveness in a year, 6 months, 3 years. And what you need to do, you need to, all of us, we need to compare ourselves with ourselves, but as well with our other colleagues. If you work in a team, you need to know what's the median, the mean of the operators group, as well who is the best performing during the period of study and who worst. Because this can influence the effectiveness, but as well other things that I will show you in a moment. And of course, if you have time to subgroup your results, depending the type of embryo transfer, diagnosis, hypofertility, and then quality of the embryos. The operator performing embryo transfer, I was saying this for quite a long time now, but even more senior than me shows that there is intervariation, and this is significant in the IVF units. So in future, perhaps, even for those that they have done thousands of embryo transfers, is the retraining and sort of adjustment of the practice through the simulation can be a solution. It's not only for trainees. So why, and this is my new experience that I share with you today, why we have to define the operator effectiveness. Imagine, let's say that I'm the worst, I have 30%, but I'm so keen and I'm good and you like it, and I'm working in a research. So all these nice things that Dr. DeSanto, the professor, said about the follicular tracking, and I make a mess. And somebody else who is doing the same thing, 50% effectiveness, it has a bias there. So there isn't any, in my best knowledge up to now, paper, even this randomized controlled trial or just a systematic review, whoever mentioned the abilities or at least to comment about the abilities of these people there. We assume that they're the same, but where is the proof? So from now on, the research should be systematic, but as well to try to talk about the effectiveness. There is a controversial evidence about the assumption that the inter-operator variability is comparable. Where is it? So can favor or more or less. And if it's a small difference, if we do a small research, this small difference can show huge benefits or bad for the outcome that we search. So I move on about, and you tell me later on what you think is a good thing. 35%? pregnancy rate, yeah, after any embryo transfer, 40, 45, 50. I have a colleague who was doing 52. And I was very lucky that I was trained with a colleague from Italy who was extraordinary. So, yeah, I mean, that's something to evaluate, because if something we don't do well, we can improve ourselves. These people that are so talented can teach us. How you can teach, you cannot be with them. How many of you really work in embryo transfer with 2 or 3 doctors? Very few. Usually you are alone and you have the nurse. How you can evaluate this? So we have to share this experience. And of course, it's not only the beginning of pregnancy. There is another parameter, conversion. I mean, you have a positive pregnancy test, and then, unfortunately, she miscarried earlier. The training, and I will finish with this. We had a hint already. The training is a little bit accumulating evidence that there is lack of standardization. Yes, colleagues from ESHRE sit down and discussed, and this 75 is a minimum, but a really minimum. In the survey that we have done, most of experts suggested 200. By the way, I have added as an annex these results at the end of the presentation for you to document or to reflect in your countries as well. So, yeah, the simulator may be the solution. So Americans started to use it, already some others tried to use it, so we have 2 things. Doesn't mean that if you do many embryo transfer, your technique evolves and develops and takes a very good level. It's a systematic, homogeneous way that you do it. And others, for example, showing much more difference between already established doctors. And that is something that we have to deal. We have to criticizing ourselves. And of course, doing this, we improve, and we improve the younger people, because we are the people that they do medicine now. If the younger people will be in 5, 10 years, the people that will replace us. That's always happening. So we have the evidence, we have everything in our hand, why we make them more difficult to do their job. The record keeping, this is a list that you can reflect and you write it down your notes. Do not afraid about medical legal problems. If you have the custom to have videos and you show here, I'm doing like that always, following the standard and so on, even if there is a complication, you can cover yourself. If you don't have anything, then you cannot prove the previous experience with talking. That doesn't work, doesn't matter anymore. So I think that it is the time now to have a unification of guideline and to finish this guideline, because we have done ESHRE guidelines about ovulation, OPU. The embryo transfer is the last one, and I will be more than happy if I can help about this, because we need to have standards and need to have guidelines that we can really, based on our research. There are objective criteria. It's not only by eyes, objective criteria, ultrasound. And ultrasound is a very clear science. Allow me to show you a very difficult case. For example, here we have an abnormal cervix, quickly. Small fibroid within, abnormal glands. You can see already that the catheter should go somewhere abnormally. In 3D, you should go in, right, up, and inside. So it's like a zigzag sort of. Hysteroscopy, intracervical adhesions, mechanical dilation at the beginning, secondary with electric, and you can see here how difficult it is. So the ultrasound helps us to anticipate. And even if we anticipate, look at a real sort of image. Here, for example, this movement is not in and out, it's just the cervix is so much blocked, so the catheter is not even inside. And this one to show, finally, it happens to go in. So yes, we are glorious, we have put the embryo inside, but when we have manipulations in and out already, your outcome is going down. And this lady still has some embryos, and we'll see what we can do in the future. So I would like to thank you for your attention. I tried to be as fast as I could. I wish that we have this sort of results more and more to our practice. And you can have my address here if you need to contact me. And thank you for your attention. Thank you.